Hello and welcome to another episode of your AKT podcast. It's been a little while since we did a clinical podcast, and in this episode things will be a little different, as rather than covering a single topic, we will present a number of questions within a single episode. I'd like to thank you for being a listener of this podcast. We've reached well over 80,000 listeners across the world. The majority of you are from the UK, but we have listeners from Australia, New Zealand, and parts of the Gulf too. Now, all of the questions from this episode have actually been taken from our newly updated mock course, which is of January 2023, has 400 AKT mock questions. Of those, there are 40 admin questions and 40 stats questions, all of which are realistic of the AKT. Now, the mock course is quite unique as it offers video explanations in a similar format to this podcast. So it's not just your written explanations that you get within the AKT. And the reason for doing this is so that you can see where we've got the answers from, what type of guidelines that we've used, so you can apply these techniques into your AKT preparation. And what we've done for this episode is we've taken the audio directly from those videos. Now, if you've liked this podcast already, you're going to love our mock course. So sit back and enjoy the next 10 questions which have been taken from our updated mock course. Just as a reference, for all our episodes, medical guidelines are continuously changing, so do keep yourself updated with your guidelines before implementing any learning points into your practice as a doctor. If you have any feedback, feel free to reach out to me on social media. My tag is WellMedicSham, or you can drop me an email at sham@wellmedic.co.uk. So in this question, you are developing a set of quality criteria for patient decision support technology. So decision aids, individuals from 4 stakeholder groups, researchers, practitioners, patients, policymakers, representing 14 countries, reviewed evidence summaries and rated the importance of 80 criteria in 12 quality domains on a 1 to 9 scale. Second round participants received feedback from the first round and repeated their assessment of the 80 criteria plus 3 new criteria. Select the single most appropriate study design. So the answer to this question is indeed the Delphi method. So the scenario is testing your understanding of qualitative research. So the Delphi method, it aims to gather a consensus of opinion, attitude, and choice of topics from selected panels without the formality of needing to meet. And you do this by using questionnaires. So the method of consensus is often limited to experts, but in some circumstances, let's say if you were trying to understand the behavior or the learned experience, then you could look at doing it from patients as well. Now, the Delphi method includes a number of stages. Initially, you have a questionnaire which is open-ended. You then take the open-ended responses and you change it to statements and standards, which has been done here. And then you ask people to rank their agreement with the statements. And that's what's happened here on the 12 quality domains on a scale of 1 to 9. And then onwards from there, you then repeat it. And as in this case, 3 new criteria was added onto that list. The other type of consensus to be aware of as well is a nominal group technique. The nominal group technique is different to the Delphi in the sense that it's based on highly structured meetings to gather information from experts on a particular issue. And now I cover both consensus methods in our stats course, so do check that out. And also check out qualitative techniques as well, as it's often poorly answered. And we have dedicated module 2 of our stats course to this. So in this question, you have prescribed Gaviscon infant for a 1-month-old breastfed infant. Which of the following administration instructions is correct? This is quite a difficult question, actually. Either if you've had a child and you've administered it, it might be an easy question. Alternatively, if you've prescribed it to a child that's breastfed, then you may have come across how to administer it as well. So in order to answer this question, we're actually going to use one of the pages taken from our WellMedic BNF summary, which is available in our AKT preparation course. And we have some specific information around Gaviscon infant there. So the answer is actually that you mix the dose with 15 ml of cool boiled water and administer with a spoon during a feed. So let's head on over in terms of administration. So this is taken from our BNF summary. If we go to Gaviscon infant and we look at administration, you can see here For breastfed infants, mix the prescribed dose with 5 ml of cool boiled water to make a smooth paste, then add another 10 ml of cool boiled water and mix, and then partway through the feed, use a spoon or a feeding bottle to give the dose of Gaviscon infant. So ultimately we are mixing it with 15 ml of cool boiled water, and then we're giving the Gaviscon infant partway through the feed. Of course, if you were giving it to a child who was using formula milk, then you would mix the prescribed dose into 150 ml of feed, shake well, and then feed as normal. Just be mindful that when you are giving Gaviscon infant, it can constipate children as well due to the sodium content within the Gaviscon infant. So there's lots of learning points that you can take away from our BNF summary. So if you are signed up to our preparation course, make sure you do use it to revise for your AKT. Now, this is a bit of a monster of a question. In this question, you have a 54-year-old patient who presents to your clinic with a several-day history of nausea, vomiting, and generalized abdominal discomfort. The patient is feeling nauseous and extremely fatigued. On examination, the temperature is 36.6, heart rate of 108, rests of 20, SATs are 99% on air, BP is 100 over 62, blood glucose is 9.4. Urine dipstick is clear. The patient is known to have hypertension, chronic kidney disease, and type 2 diabetes. The medication list for this patient includes ramipril, metformin, dapagliflozin, atorvastatin, and aspirin. Select the single most appropriate first-line investigation. So the answer to this question from the list that we've shown you here is blood ketones. Okay. So this is a really, really complex question and definitely amongst the more difficult questions within this mock exam. Now, firstly, we have a relatively vague clinical scenario with some borderline observations for the patient. The likelihood here is that we would look at the differential list first and foremost, right? So when we think about a question like this, we would probably think, could this be gastroenteritis? Could this be a pancreatitis? Could this be an acute kidney injury? But with the information available, we have to have a high suspicion of ketoacidosis. I'll come to why that is now. Now, probably the things that puts you off and thinks, well, could this be a ketoacidosis, is the normalish glucose, because actually the glucose isn't very, very high. It's 9.4. Okay, so what you have to consider here is euglycemic ketoacidosis or normal glycemic ketoacidosis, which is basically ketoacidosis in light of a normalish or not significantly elevated glucose level. And you have to be cautious of that because this patient is prescribed dapagliflozin. So that's the little bit of a hint within the question. So the way that we're going to answer this question is we're going to look at the BNF, okay, for dapagliflozin, and within the BNF of dapagliflozin, there is an MHRA update here, which is the risk of ketoacidosis with SGLT2 inhibitors, so things like canagliflozin, dapagliflozin, and empagliflozin. Okay, and the reason why this is actually really, really important and topical at the time of recording this is that the indications to prescribe these medications has increased, and therefore we're going to see more patients taking these medications. So first of all, let's think about the symptoms of DKA. So symptoms of DKA include rapid weight loss, nausea, vomiting, abdominal pain, fast breathing, sleepiness. They can have a sweet smell to their breath. They may have a sweet or metallic taste inside their mouth, and they may have a different odor to their urine and sweat. Okay. Now, as you can see here, you can see in several cases the presentation of DKA was atypical, with patients having only moderately elevated blood glucose, and some of them occurring off-label use. Of course, the off-label use isn't necessarily important here, but the thing that we need to remember is that really we need to be testing for raised ketones in patients with signs or symptoms, even if plasma glucose levels are near normal. Okay, so the other thing that you have to remember in this scenario, or what makes this scenario trickier than your normal scenarios, is that with euglycemic ketoacidosis, you cannot rely on urinary ketones. So although the urine dipstick is negative, you absolutely have to test for blood ketones. So in euglycemic ketoacidosis with SGLT2 use, urine ketones can be normal. Therefore, the answer to our question here is blood ketone levels. Okay, now other findings that you can expect with ketoacidosis, of course, are more secondary care findings in the sense that you can expect that patient would have a low pH, they may have raised or normalish BMs, and you would expect on a blood gas that they would have a low bicarb. But the key thing here is prompt diagnosis, high suspicion, and referral into secondary care. So just be mindful of this, especially as SGLT2 use is becoming more widespread. One of the risks or one of the difficulties that you might have in your general practice is that sometimes our ketone monitors are actually linked to blood sugar monitors. So if the blood sugars are high, then you get a reading of the ketones. Otherwise, you don't get a reading of the ketones. Just be careful of this and make sure that wherever you're practicing, you know where the closest ketone monitor is, where you could check a patient's ketone levels immediately. So in this question, you have a patient who has recently relocated to the UK from Slovenia. She reports extreme fatigue, intermittent fevers, and night sweats. She also describes generalized joint and muscle pain on examination. She reports her body aches can vary in terms of location and severity. Initial blood screening is normal. This includes a full blood count, renal profile, liver profile, CRP, ESR, ferritin, thyroid function, and celiac screen. Select the single most appropriate investigation. So here you have a number of investigations that you can choose from, and the correct answer to this test is the ELISA test. So in order to answer this question, we're going to look at a couple of resources, and the first one that we're going to look at is a resource which is from the WHO, and this is a very useful resource in the sense that it's got lots of factual information around Lyme's disease in Europe. And Lyme's disease is a condition which is common in Europe. And the clue in this question is very much around the migration from Slovenia, which has a high incidence of Lyme's disease. In addition to that, especially in Central Europe, you have places like Czech Republic, Estonia, Lithuania, and Slovenia, which have high incidence of Lyme disease. Now, if we go back to the NICE guidance on Lyme disease, then there is a lot of information in the new NICE guidance for Lyme disease in terms of how Lyme disease presents. Now, generally speaking, if a patient presents with erythema migrans, which we do cover in another question within this mock, then it makes the diagnosis much easier. However, there are other symptoms that we need to be mindful of as well. So if I go down here to 1.2.3, you will see that you should consider the possibility of Lyme's disease if people are present with several of the following symptoms. Although Lyme's disease is uncommon, it's a possible cause. So we have things like fever and sweat, swollen glands, malaise, fatigue, neck pain or stiffness, migratory joint or muscle aches and pain, so as in it's moving, which is something that was described in this scenario, cognitive impairment, headache, and paresthesia. Now, in terms of how we test, the best resource to actually use is the NICE visual summary on testing, which can be found on the NICE guidance. Now, it's quite a straightforward algorithm in terms of how we follow this. So, suspect Lyme disease. Is there a rash present? No, there isn't. Therefore, you would offer the ELISA test. The ELISA test will test for IgM and IgG. Now, IgM is for the acute phase. However, one of the things to remember here is that if an ELISA test is negative, okay, you can review other symptoms. However, if the symptoms still remain after 12 weeks, then you would still go on to do the immunoblot test. Alternatively, if the ELISA test is positive, then you would go on to offer an immunoblot test to the patient. If the positive immunoblot test, then you can offer diagnose Lyme disease and offer antibiotics. If the immunoblot is negative, then at that time you would consider alternative diagnosis or consider referral to specialists. One of the things to remember within the guidance, if you have a read through the guidance, which I would highly recommend, is that you will find that if at any stage of investigation, even at the ELISA test, if you have a strong suspicion that this patient may have Lyme's disease, then you would go ahead and start antibiotics. So in this case, an elderly patient with known depression has a significant history of multiple overdoses. He's currently on daily prescriptions. He's attended your clinic with an acute ankle sprain and would like to be prescribed cocodamol 3500 for 2 weeks. You have agreed to do the script, however, you are unwilling to give the patient a 2-week supply of the medication. Which of the following ethical principles is likely to be upheld in this scenario? So you've got autonomy, beneficence, non-maleficence, or justice. And the answer is C, non-maleficence. So ethics are really important and they are covered within the RCGP curriculum guide. In this scenario, the principle of beneficence and non-maleficence are obviously very closely related, as is the case in most scenarios. So just to quickly recap over the 4 principles, autonomy is the capacity of a patient to make free choice. Beneficence is to do good, to act in the patient's best interest. Non-maleficence is to do no harm, and justice is to ensure fairness. So in terms of this scenario, there is some benefit of the analgesia requested. However, given that there is a high suicide risk, it is the duty of the doctor to ensure that no harm happens to the patient. So a 2-week script of an opiate-based medication with someone who is deemed so high risk that they're on daily scripts would imply a degree of harm, which is why the answer to this question, in my opinion, would be non-maleficence. Now, the challenge of ethical scenarios generally is that you could argue that this is a best interest decision, and which is important. However, in that case, you would then argue that beneficence is most likely to be upheld. However, because of minimizing the risk, I would say that this is more in keeping with non-maleficence. So in this question, you have a vague scenario of a 45-year-old patient who is presented with an acutely swollen great right toe who otherwise feels well. So the first step of this question is to think about what the question is telling you in terms of what the presentation is, and then answer the actual question, which is which of the following medication is the least likely cause. So the answer that we've gone through here is methotrexate. Now, the presentation, based on the limited information that we've got here, is likely to be gout. Okay, so what I've done is I have used a journal which was taken from the rheumatology journal, and it's this paper here, which is drug-induced hyperuricemia and gout, and within that there is a table, and within that table there are common drugs which lead to hyperuricemia. So these are all the common drugs that lead to it, and from our list, methotrexate is not in that list, and it actually gives you some information about how they affect the uric acid. Now, there's one other paper that specifically comments on methotrexate, and this is a poster presentation which was included in the BMJ journals, and within that, there was some evidence to suggest actually methotrexate may lower serum uric acid levels. So again, this question is challenging, probably challenging than most questions within this mock or the AKT itself. And I guess one of the things to consider is one of the realities of the AKT is that you can't know everything, and just making sure that you don't panic if you get a question like this, and making sure that you can, try and work it out if you can, and if you can't, just move forward. So this is quite an interesting question, and probably something that we will all encounter at some point in our work as GPs. So you have a 45-year-old patient who is perimenopausal and experiencing regular hot flushes, poor sleep, irritability, and headaches. She is taking extended periods of leave from work as a result of her symptoms. The patient takes no regular medications. Past medical history includes a hysterectomy. Her BMI is 35. What would be the single most appropriate treatment for this patient? So the single most appropriate treatment for this patient is transdermal estrogen. So similarly to some of the other menopause questions that we've covered, managing the menopause can be incredibly complex. Now, there are a few things that we need to first pick out of this scenario. So what do we have in this scenario? So we have a perimenopausal patient who does not have a uterus. Okay, so they've had a hysterectomy. And when a patient doesn't have a uterus, Generally speaking, unless they've had a subtotal hysterectomy, the patient does not need progesterone. The patient has had quite significant symptoms, and from the history that we've been given, we've not been given any obvious contraindication to the prescription of hormonal replacement therapy. So really, the thing that we need to consider here is, of all the options that we have, all of which can be used in some form or another for the treatment of the menopause or perimenopause, we have to make a decision between whether we prescribe either transdermal estrogen or whether we prescribe oral estrogen. So if I load up the nice CKS on menopause, this can be a helpful guide in terms of hormone replacement therapy. And the reason why I bring this up is around the risk with VTE. So as you can see here, the risk associated with transdermal HRT given at standard therapeutic doses is no greater than the baseline risk. And furthermore, we know that when, and you can find this within the CKS, but if a patient has a BMI of more than 30, then the general advice is to offer transdermal HRT preparation over oral HRT. And I'll just try and find that for you guys here. There you go. Women with increased risk of venous thromboembolism, consider the use of transdermal rather than oral HRT for women at increased risk of VTE, including women with a BMI of over 30. So in our scenario, we have a patient who has a BMI of 35. Therefore, we have to consider what the risk of VTE is. And as a result of that, transdermal estrogen would be the most appropriate for this patient. So in this question, a study assesses the outcome of physician burnout on patient safety incidents. The odds ratio is 2.04 with a 95% confidence interval of 1.69 to 2.45. Select the correct statement that applies. Statement 1 is that physician burnout is not of concern in patient safety incidents. Number 2 is that the evidence supports an increase in patient safety incidents with higher levels of burnout. That is the correct answer. And finally, the evidence does not support an increase in patient safety incidents with higher burnout. To understand this question, we need to understand and focus on odds ratio. So the odds ratio is the ratio of probability that an event of interest occurs to the probability that it does not. Okay, so what that effectively means is if you have an odds ratio of 1 means that exposure does not affect the outcome. So in this case, if we had an odds ratio of 1, that would mean that there is no difference in patient safety incidents. An odds ratio of less than 1 would mean that burnout is higher burnout leads to less or a decrease in terms of patient safety incidents. So that is not the case that's going on here, because in here we have an odds ratio of more than 1. So if you have an odds ratio of more than 1, it basically implies that there is an increase in the outcome. So what that means is that there is a higher number of patient safety incidents associated with higher burnout levels. So in this question, you are concerned with the professional conduct of a physiotherapist working within your general practice. Which of the following agencies would you escalate your concerns to? So the answer to this question is the Health and Care Professionals Council. We have a list of regulatory bodies within our AKT admin course under professional regulations. Again, this type of question comes under knowing the broader team that works within primary care. So physiotherapists are managed by a broader category of health and care professional councils, and this is where you would report your conduct concerns to, just as you would report conduct concerns for doctors to the GMC and nurses and midwives to the NMC. in this question, you have a 78-year-old patient who has presented to you with progressive shortness of breath. On examination, you auscultate a new diastolic murmur on the left sternal border. Initial investigations show hemoglobin of 118, white cell count of 15.2, platelets of 340. The urine dipstick shows microscopic hematuria. Which of the following investigations would be first line? And the answer to this question is transthoracic echocardiography. Other options that you may have considered here was the transesophageal echocardiography, and I will explain why transthoracic is the first line investigation. So this is quite a tricky question given that the information provided is quite limited. The scenario here, you can have two right answers, and in reality, many ways in which you might approach this patient's care. But the first and most important thing to highlight here is that the patient has presented with a new diastolic murmur on the left sternal edge, and that's most likely to represent an aortic regurgitation murmur. Now, in addition to this, they have microscopic hematuria, and they also have a raised white cell count, and they have a relative anemia as well. Now, all of these things can be found in infective endocarditis. So considering the different features that we've got here, you can make a possible diagnosis of infective endocarditis. Now, I could have, of course, made this scenario more obvious and said there's splinter hemorrhages and so on, but I think that would make the scenario easier than what I was trying to do. So I think there's still some level of difficulty in terms of coming to the diagnosis. Now, the second part of the question is now knowing what the scenario may be and therefore deciding on the first line investigation. Now, let's say you went for another type of investigation here, like cystoscopy. The alternative thing that you may have seen was an elderly gentleman who's got microscopic hematuria and a raised white cell count, and then that would go down the route of bladder cancer. However, the whole idea of this was not necessarily going down the route of bladder cancer. It was more for you guys to focus on infective endocarditis with the new diastolic murmur that's present. Okay, so now that we've had a slight trick within the scenario, we'll now move on to this guideline here. So this is taken from the European Society of Cardiology, and it's a full cardiology-based guideline on the diagnosis of infective endocarditis. Now, the reason why I wanted to bring this in is that if it just shows this algorithm, just sums up exactly what I'm trying to get across here, that transthoracic echo is recommended before transesophageal echo. So following the transthoracic, there is then information as to whether or not you would go down the route of doing a transesophageal echo. Now, I appreciate that this is quite secondary care based, but one of the things to know about from the RCGP curriculum is what type of investigations take place in secondary care, and this is a good example of that. Now, I'm sure if you've worked in a hospital and you've come across a potential infective endocarditis, you'll be well aware that patients tend to have transthoracic echoes before they can even get close to having a transesophageal echo. Okay, now just be mindful of murmurs, be mindful of how murmurs are described, because that will help you in your questioning as well, and just consider what the differentials could be for a patient presented with chronic shortness of breath as well. This podcast is hosted by wellmedic.co.uk. We help GP trainees pass the AKT.